now that we know that the perioperative space is
Changing.
evolving, what do we
Yeah.
do in the metastatic setting?
That's what we're all waiting to see. I think their press release a few days ago, so I think that we'll have some good
Ah,
information here shortly about perioperative EV pembro, and that's going to change everything.
right.
And we're going to have the same discussions about if somebody has this great response and they recur, and you think that they have been cured of their disease and they recur 6 months later, or they end up having recurrence 3 years later. What
Right.
does that interval of time mean to us with regard to our first line regimen? What does it mean with regard to resistance to EV? What does it mean with regard to resistance to checkpoint inhibition? So, all I can say is that that is a huge area of unmet need. I think it's one that is like we're all sort of teetering over this edge of looking over and wondering what it's going to be like and sort of prepping for it. And it's an interesting thing when it hasn't happened yet, but
Right. It is. But I think, you're referring to the press release for one of the EV pembro arms for cisplatin ineligible
yeah,
patients. The question of do they need the full sandwich will also not be answered by the results of the trial. Uh,
nope.
so to your point from your discussion, that neuropathy, we may cure patients, but are they going to also have neuropathies? So
And is
that's
it
what.
going to be, I feel like the parallel in the metastatic setting, when EVP was initially in use for cisplatin eligible patients, and then we're awaiting EV302. I think it's important to also not get ahead of ourselves. It's important to realize that the comparator arm in any study of cis ineligible patients is not ideal. Sometimes it's just go to cystectomy and then consider adjuvant therapy after that. And so we can't assume, pending, how that we get the full results of that study, that it will be exactly the same in our cis eligible patients. I think it would be normal and human to think that, but that's why we have
Right.
data.
Right. No, and that's a great point. So to close us out, what studies are you excited about that haven't read out yet, otherwise in the urothelial cancer space?
Yeah, I mean, I think that is probably my most exciting one is perioperative EV and cis eligible and cis ineligible. It's going to be a very long time till we have modern data. And when I say modern, I mean Matt Galsky's study of ctDNA adjudicated adjuvant therapy, whether they get intensified immunotherapy or standard nivolumab or surveillance with ctDNA monitoring. But I am really excited about sort of that ctDNA space and that knowing, I think of it as, it's the MRD. It is the minimal residual disease. It is a marker of metastatic disease. And so I think it belongs in the conversation about metastatic urothelial cancer. If somebody turns positive or is positive, we learned at ASCO basically from Tom Powell's ctDNA analysis from Niagara, that those patients are really likely to recur unless we never really say this out loud, but unless their immune system is somehow able to do surveillance and get rid of that MRD on its own, which those
Right.
Kaplan-Meier curves would tell us that's really unlikely to happen.
Right.
Um, and so I think that that's really going to be important in the metastatic space too, because right now in clinical practice, if we're getting quarterly ctDNA, we can also have a whole different conversation of should we be doing that if we're not acting upon it outside of a clinical trial.
Right.
But we get it and it turns positive. Like, what do? We just get nervous and we just have upsetting conversations with our patients. For the
Right.
moment, yeah, I mean, I am not starting EVP in patients who have positive ctDNA, but nothing detectable. But maybe we'll find out sometime in the future that we should be, that there's this window for curing those patients that we don't want to have close on us. But I think that that's going to be really telling.